Am I standing too close? Good morning, everybody, and welcome to the 8th Orange County Women's Health Summit. My name is Allison Sonnenschein, and I am the founding director of the Orange County Women's Health Project, and it really is our pleasure to welcome you today, especially online. So this is the third session of a 4-part summit that will address women's health in the age of COVID-19. We hope you will attend all 4 sessions, which I'm going to review very briefly. The first session, which was on May 29th, provided a high-level overview of how COVID-19 is impacting women's health. We also had an update on what's happening at the federal level to respond to COVID-19, and a very rich discussion with panelists explaining adverse childhood experiences, otherwise known as ACEs, and the interplay with ACEs and COVID-19. The second session, which was last Wednesday, June 3rd, explored how COVID-19 is impacting sexual health and education in the county. Today, the third session, we will discuss what are the women's health policy implications of COVID-19. And the fourth and final session, which is next Wednesday, June 17th, will address COVID-19 and mental health. Next slide, please. So today's program should last about 90 minutes, but before we dive into the program, I'd like to cover a few quick logistics and also offer some thanks and recognitions. Next slide, please. So first, I wanted to acknowledge that this session, along with all of the sessions, is being recorded, and we will upload the video recording of the session to our Summit website. And if you look in the chat feature of your Zoom screen, you will see a link to the Summit website page where the recording will be uploaded probably later today, if not by tomorrow morning. We will also share all of the presentation slides from today's presentation on the Summit website. Now, if you have questions, we have enabled both the Q&A feature and the chat feature for slightly different purposes. If you have questions about the content of the presentations that you'd like to submit to the speakers, then please use the Q&A feature. But if you need any kind of technical support, then please use the chat feature. We will be holding all questions to the end of the presentations, and we will then have a moderated Q&A session. But if we don't have time to answer all of the questions, we will try and follow up with the speakers and post the answers to those questions on the website sometime later this month or sometime in July. Next slide, please. At the end of today's presentation, you will be automatically directed to a new web page where you will find an evaluation survey. We greatly appreciate your completing the survey to provide us with important feedback and suggestions on how to improve these summits in the future. You will also, at the end of completing the evaluation survey, receive a link to a CEU request form. So if you are interested in receiving continuing education units, which are available today for chess, nursing, LMFT, LCSW, LPCC, and LEP, then you will have to separately complete the CEU request form. So just to clarify, you must complete both the evaluation survey and the CEU request form in order to receive your certificate for CEUs. Finally, I'd like to mention that we are really excited to share with you 6 poster presentations also available on the Summit website. And if you look in your chat feature, you'll see a link to our Summit website page where you can review 6 virtual poster presentations about interesting women's health issues in Orange County. And we want to thank our poster presenters for adapting from a physical poster to a digital poster presentation with a narrative recording as well. Next slide, please. This summit would not have been possible without the extraordinary generosity of our sponsors. And I'd like to start by thanking our lead sponsors at the ambassador level, the Arduous Family Foundation, at the champion level, Carrie and Danny Sonnenschein, Sheila and Igal Sonnenschein, and the California Wellness Foundation. And at the guardian level, the Shaw family and Planned Parenthood of Orange and San Bernardino counties. We also have at the advocate level, Pamela Gilmore and Hoag Women's Health Institute, and the activist level, Allison and COVI Sunshine, a little embarrassing, Suzanne and Richard Wagner, the Francesca and Giovanna Family Fund, Cal Optima, Orange County United Way, and 501c Insight. So thank you again for your generosity. And in particular this year, this generosity enabled us to present this summit series at no charge. Next slide, please. I'd also like to thank the members of the Orange County Women's Health Project's Advisory Board, many of whom have been with us from the very beginning, and it is such a privilege to work alongside these champions for women's health. And of course, our team. You will, or maybe you've already seen my colleagues, Dina Rubin. Today you'll meet Mona Shah, and next week you'll see Gail Dratch. But behind the scenes and working so hard is Sydney Minchin, our program and events coordinator, who has done a phenomenal job adapting our in-person conference to a 4-part virtual summit series. So thank you, Sydney, and to the extended team as well. Next slide, please. Okay, so before we begin, we briefly want to get a sense of who's in the virtual room. So we're going to do a very quick poll, and we will ask that you just tell us about yourself. Sydney, if you could please post the poll. Okay, if you could please, we have one question. Use your Zoom poll feature to answer this question. What do you do? If you are working outside of the home, then please select whichever title applies. And if you are not working outside of the home, or if you're retired, please select the first option, community member or volunteer. We'll wait about 5 or 6 more seconds and then we'll review. Okay, Sydney, could you please post the results? Okay, so it looks like we have the most educators, faculty, and health educators in the room. We also have a fair number of nonprofit and community-based organization staff, community members, students, welcome, researchers, nurses, social workers, therapists, and counselors. Looks like we don't have any physicians or PAs today, but thank you all for sharing this information. And Sydney, you are welcome to close out the poll. Next slide, please. Next slide. Next slide to master slide 10. We're going to move on to the policy panel now. Wonderful. It is my pleasure, now that we're moving to the real body of today's summit session, it is my pleasure to introduce our moderator of this panel, which will focus again on the policy implications for women's health that have arisen during or in response to COVID-19. Our moderator today is Aurora Garcia Barrera, who is the Director of Policy and Government Affairs for the Coalition of Orange County Community Health Centers. And in this role, Aurora is responsible for overseeing the policy and advocacy campaigns that are responsive to the needs of the community health centers and the patients they serve in Orange County. Prior to joining the coalition, Aurora was the community engagement manager for the Children's Partnership in Los Angeles, and she has extensive experience with community organizing. She earned her bachelor's in sociology and Chicano studies at UCLA. Thank you so much for joining us this morning. Aurora, I'm going to turn it over to you now. Next slide, please.
Good morning, everyone. Thank you, Allison, for that lovely introduction. I'll start off by saying that I really appreciate the opportunity to be here with you all to moderate this panel discussion about COVID-19 and women's health policy. I wanted to just, before we get started with introductions for our panelists, I wanted to go into what this panel will be exploring, which will be broken down into 3 different sections. So first, we will go into legislative and regulatory changes that have already happened in response to COVID-19 that advance women's health. Then we will go into litigation that has arisen in response to COVID-19 to protect women's health, followed by policy considerations for post-COVID recovery phase. And now it is my pleasure to introduce our panelists. So our first panelist will be Allison Sonnenschein, who is the founding director of the OC Women's Health Project. Allison has over 25 years of nonprofit, legal, and volunteer experience in women's health. In 2011, she founded the Orange County Women's Health Project, a nonprofit dedicated to advancing local women's health through education, collaboration, and advocacy. Prior to the OC Women's Health Project, Ms. Sonnenschein was the Special Projects Officer for the Mirage Foundations, where she helped establish the SOS El Sol Wellness Center, now a federally qualified health center located at El Sol Academy, a Title I charter school in downtown Santa Ana. Prior to that, Allison was a litigation attorney with Bingham McCutcheon, now known as Morgan Lewis, in Los Angeles, where she performed pro bono legal services in the reproductive justice and domestic sexual violence movements. Ms. Sonnenschein has served as a board chair for both Essential Health Access and Planned Parenthood of Orange and San Bernardino counties. She graduated with honors from the University of Pennsylvania and earned her JD at the USC School of Law. Our second panelist is Mona Shaw, who is the policy advisor for the Orange County Women's Health Project. Mona is an independent health policy consultant and works primarily with nonprofit organizations, philanthropies, and government agencies. Mona has served as a project director for the Health Funders Partnership of Orange County and as a consultant with the OC Office of Health Management Associates. Prior to that, Mona was a senior health policy advisor to U.S. Senator Barbara Mikulski, as well as staff director for the U.S. Senate Subcommittee on Children and Families, Committee on Health, Education, and Labor and Pensions. In this role, Mona drafted several sections of the Affordable Care Act and spent time working on health-related legislation and appropriation issues. Mona currently serves on the advisory board for the Orange County Women's Health Project and the board of directors for Essential Health and Pretend City Children's Museum. Mona earned her JD from University of Maryland School of Law and her Master's in Public Health and Bachelor of Science from Emory University. So before I hand it back over, I just want you all to send some virtual love to our beautiful panelists, and I hope that you all enjoy this discussion. So now I will hand it back over to Allison to begin.
Great. Thank you so much, Aurora. Okay, to begin, we are going to, first slide, please, talk a little bit about what is the current state of COVID-19 in Orange County. We've done this at all of the summits, and I think it's particularly important today as we're going to be exploring the policy implications to understand how COVID-19 is affecting the county. So next slide, please. So the first slide is actually just a reference where you can find information and resources. The Orange County Healthcare Agency is maintaining a dedicated website for COVID-19, a referral telephone line that operates during the week, and a variety of resources that you can download and link to concerning the case counts, testing sites, frequently asked questions, the state and county health orders and recommendations. We have a separate link to on this slide. And finally, the data, not only the case and death counts, but also how these counts are being tracked by gender, by race and ethnicity, by age, and by city, as well as what's happening with the number of tests that have been administered, the number of folks who've been hospitalized, are in the ICU, and who have recovered from COVID-19. Next slide, please. So as of yesterday, Tuesday, June 9th, we had 7,614 cumulative cases of COVID-19 documented in the county. I just want to acknowledge that when we started the summit on May 29th, we had about 5,744 cases documented at that time. So we've seen an increase of almost 2,000 cases in the last 10 days. And as of today, 49% of those cases are among women and 51% among men, 0% unknown. So that tracks pretty closely to the population overall in Orange County by gender. It's slightly more than 50% female and slightly less than 50% male in Orange County, according to the census figures. So this skews a little bit opposite, but pretty close. In terms of the death count, as of yesterday, we had 185 cumulative deaths from COVID-19 documented in Orange County. That's up from 145 deaths recorded on the first day of the summit on May 29th. But here we see a slightly more pronounced disparity among men and women. And in fact, it is men who are bearing the brunt of COVID-related deaths in Orange County. We can see there's 44% of COVID-related deaths among women and 56% among men. So men are more likely to die from COVID-19 than women. And this is not true just in Orange County, but also throughout the country. We are seeing a greater impact in terms of the mortality rates among men than women. Next slide, please. Now, this pie chart illustrates the breakdown of COVID-19 cases as of yesterday by race and ethnicity. And I just want to qualify or issue a caveat that, as you can see, the bright blue section of this particular pie chart shows that 27% of Orange County cases, we don't know the race or ethnicity. That's such a large percentage of the overall number of cases that it suggests that the rest of these numbers are not that reliable. And so I wouldn't draw any firm conclusions. These figures are changing daily, but with such a large quantity of unknowns, we really cannot determine to what extent there are racial and ethnic disparities at play with regard to the case count. We are seeing cases and deaths affecting African American men in particular at the highest rates throughout the country. But we haven't seen that materialize just yet with the data we have currently available in Orange County. Next slide, please. So this pie chart illustrates the death count. Now here we have more reliable information because, as you can see, only 1% of the deaths in Orange County related to COVID-19 are unknown. And you can see it's a pretty wide distribution of deaths among the various races and ethnicities in Orange County. And this breakdown tracks pretty closely to the demographic breakdown by race and ethnicity of the overall population in Orange County. And if you're interested in doing that comparison yourself as we move forward, you'll see that I've included links at the bottom of each of these demographic slides where you can find the overall Orange County population breakdown by age, by gender, and by race and ethnicity. So you can see how the COVID case breakdown and COVID death breakdown is tracking against the overall population breakdown. Next slide, please. Here we have pie charts illustrating the COVID cases and deaths by age in Orange County. And this is a really interesting set of charts. We all suspected that in the early days of COVID-19, it was established that our senior population, ages 65 and older, were at the greatest risk of COVID-19 complications and death. And in fact, that's what's playing out here in Orange County as well. If you see on the chart on the left, I realize these numbers are really small and tough to read. So if you click the links at the bottom, you can get to the original source and you can expand them. But as you'll see on the left side, the case distribution by age, 77% of all COVID-19 cases are among adults ages 18 to 64. But this same age range, adults 18 to 64, represent only 25% of COVID deaths. And the opposite is true for our seniors. And I'm defining seniors here as 65 and above. About 20% of the overall case count in Orange County is affecting seniors, but 75% of all COVID-related deaths are among this senior population. We do have a very small number of children ages 0 to 7 who have contracted COVID-19. Thankfully, 0 deaths among children ages 0 to 17 due to COVID-19. Thank you. Next slide. Finally, the Orange County Register is publishing on a daily basis a map that illustrates by city the case rates. So what you can see here is that the cities that have the highest case rate per 10,000 residents are highlighted in the darkest of the red shade. And that appears to be concentrated in the central part of the county. Santa Ana, Anaheim, and Garden Grove have the highest central county case rates. But we also see in the chart on the right-hand side, just the case counts, where we have a slightly different ranking. And interesting, so in other words, it is not always the case that a city with the highest case rate is also the city with the highest case count. That is true at the very top of the list, but as we move down, we find that a slightly different ordering. And one standout example, Los Alamitos, which doesn't even appear on this list of the cities with the highest case count, has one of the highest case rates. So the Register is tracking this daily, and you can link to that yourself at the top link on this slide. Thank you. Next slide. So that is an overview of where we are today in terms of how COVID is playing out in the county. I would like to take a moment and just discuss at a very high level, why are we even bothering to talk about the policy implications for women? It's because women are facing unique challenges related to COVID-19. Next slide. So there are a variety of areas where women are experiencing a disparate impact from COVID-19. Domestic violence. There is an increase in family violence happening right now as people are sheltering in place. At the very beginning, the first week or so of the shelter in place order, we're talking about the second week of March. Interestingly, the calls to domestic violence and hotlines and the calls to law enforcement for domestic violence related assistance went down. We believe that's because domestic violence victims were now being forced to shelter in place with their abusers and were unable to find a private time or a private location to make a call. But as we've adapted to these shelter in place orders, and as we've moved through time, we've seen the number of calls increase exponentially, especially to domestic violence hotlines in Orange County. And this has obviously long-term repercussions with all of the health-related consequences and desire for legal and housing assistance for these domestic violence survivors who've been forced to live and shelter in place with their abusive partners. The second area where we're seeing women impacted uniquely is, of course, with pregnancy. So there's some medical evidence that women who are pregnant are at higher risk for serious complications from COVID-19. And of course, the top question for any pregnant woman is, if I get COVID-19, am I going to pass it to my baby? And so far, there's almost no evidence that that is likely to happen. There have been about 4 studies of pregnant women who have COVID-19 at the time they deliver. And across those 4 studies, granted the number of patients involved in the studies are very small, but fortunately of those, across those 4 studies, there were only 3 newborns who tested positive for COVID-19. However, we don't know whether the newborns contracted COVID-19 in utero, during the childbirth delivery, or after by being exposed to someone, whether it was the mom or even a healthcare provider who may have been contagious. So there is little to no evidence of vertical transmission in utero, but it is certainly possible. The other good news is that there's been no evidence of COVID-19 being found in breast milk. Excuse me, the third area where we're seeing a disproportionate impact on women is in the area of caregiving. So schools are closed, childcare facilities are closed. Grandparents and aunts and uncles who often contribute very meaningfully to childcare are sheltering at home, and grandparents in particular are at higher risk and have been advised to stay away from children. And so for working parents, this is causing a tremendous strain in that children who are now having to do distance learning often need, especially if they're younger children, they need some help from their parents to get onto their Zoom or whatever the virtual platform is. And we're finding that this burden of child care and caregiving is falling disproportionately on the moms, and especially in single parent households, which in this country are overwhelmingly headed by mothers, by women. When they have no other childcare options, this means that they're going to have no choice but to take on this additional childcare responsibility, often to the detriment of their own productivity or employment. We're also seeing this on the other end of the spectrum for adults who care for their elder relatives and for older adults. And it plays out both ways. On the one hand, you have adults who are providing caregiving responsibilities for seniors who now are responsible for doing the grocery shopping, picking up the prescription drugs at the drugstore, maybe making additional meals for these seniors. And so there's additional time-consuming tasks associated with this caregiving because seniors are sheltering at home. But on the other hand, if seniors are in a facility that's under lockdown, there's a lot of guilt and mental health issues associated with adults who are typically responsible for caregiving now being unable to fulfill those responsibilities. So whichever way it cuts, we're seeing impacts on women who are overwhelmingly responsible for caregiving, both for children and for seniors in this country. This also relates to the fact that women constitute the majority of the essential frontline workforce in this country. And as caregiving responsibilities increase, that means that women's ability to fulfill their employment responsibilities is put into jeopardy. It also means that women are taking on additional risk just by going to work because they're not able to shelter at home. And we're seeing that in certain sectors where women constitute the majority of the workforce, like hospitality, retail, hotels, restaurants, they're suffering a disproportionate percentage of job loss and wage loss associated with the reduction of hours or being put on furlough. And for those who have employer-based health care, then they're losing their health insurance as well. These disparities affecting women in the frontline workforce are even more pronounced for women of color, who represent the greatest percentage of the frontline essential workforce. Women of color also suffer a double pay gap disparity. So women overall are paid less than men, and women of color are paid even less than white women. And so for women of color in the frontline workforce, they are experiencing significant disparities when it comes to job loss, wage loss, health insurance loss associated with COVID-19. Finally, I just want to acknowledge that during a pandemic, we are finding that women are foregoing their preventive care. This is true across the board because medical practices have had to close for all but urgent visits, and it is just more difficult for people to justify taking the risk of going out in order to seek preventive care if it's not truly urgent. But what does this mean? Last week, we learned that in the first few weeks of the shelter-in-place order, that visits to the STD clinic run by the county, by Planned Parenthood, and Radiant Health Centers all dropped by about 50%. In the weeks since then, the visit counts have increased pretty steadily, but what we're seeing is that people are not going in to get screened, tested, or treated for STDs. Fortunately, all of these providers have been able to adapt, and they're now offering contact-less telehealth visits, drive-through visits, and a number of STD tests can actually be performed at home and sent into the lab. So we do think that this is changing for the better. Unfortunately, on the other hand, women are unable to seek screening mammograms, and well woman visits during which a Pap test would be performed are also temporarily suspended. So in this sense, women are forgoing their preventive care, and we don't know for how long this is going to last. Next slide, please. This is just a quick infographic that illustrates that women are the essential workers in the sectors that are being affected most by the COVID-19 pandemic. You can see here, this is based on data from the American Community Survey, that women represent 75% of people who work in hospitals, 88% of those who work in psychiatric, nursing, and home health aides, and so on. And I just want to acknowledge that this is different than what we've experienced in the past. In the last Great Recession of 2008 and prior recessions, the industries that were affected most by job loss and wage loss caused by the recession were male-dominated industries, such as manufacturing, in particular auto manufacturing in 2008, as well as construction, in particular home construction and building improvements. These were the industries that were most impacted. And as a result, it was men who were disproportionately impacted by job loss and wage loss and the loss of health insurance. This is different this time around, and it is women who are being disproportionately impacted by the COVID-19 pandemic and the ensuing recession. Next slide. Okay, I'm now going to turn it over to my esteemed colleague, Mona Shah, also my dear friend, who's going to walk us through what's happening legislatively at the federal level, as well as with the state budget. Thank you.
Thank you so much, Allison, and to the entire Orange County Women's Health Project. Okay, sorry about that. We realized that I was still muted. I wanted to thank Allison and the entire Orange County Women's Health Project for inviting me back this year to help with the policy update. It's great to be with everyone virtually, and I'll be honest, it was nice to put on something other than pajamas or workout clothes this morning. So I'm just going to dig right in, and I'm going to focus my portion of the update on some federal legislative developments, as well as focusing on the new California budget revise that came out in May. Next slide, please. So some of you may be familiar, there were 5 major pieces of federal legislation that have been passed and signed into law, all related to the COVID-19 pandemic. The first one was relatively early on in the beginning of March, known as the Coronavirus Preparedness and Response Supplemental Appropriations Act. And that one was just to focus on coronavirus vaccine research and development. The second one, known as Families First Coronavirus Response Act, focused on providing paid sick leave, tax credits, and funding to assist with free COVID-19 testing. It also expanded food assistance and unemployment benefits, and included some provisions for increased Medicaid funding for states. Something interesting to note, some of the paid sick leave provisions only applied to employers who had employees under 500 in terms of numbers. California, actually, in April, the governor decided to sign an executive order to give at least up to 80 hours of paid sick leave, specifically to food sector workers when their employer was over 500 individuals. So that was something good to see come out of California. The third piece of legislation is probably the one that everyone is most familiar with. It's known as the CARES Act, and it stands for the Coronavirus Aid, Relief, and Economic Security Act. This bill is significant for many reasons, primarily because it is literally the largest single economic rescue plan in the history of the U.S. The country has never spent more on a single bill, and it costs $2.2 trillion. In that, there was $500 billion in direct payments to Americans, $208 billion in loans to major industries, and then $300 billion in small business administration loans. It also included something known as the Paycheck Protection Program, again, something many of you are probably familiar with. Nowadays, a lot of people refer to it as the PPP, that allows employers to continue paying for their workers. And then following that, a few weeks about a month later, there was the Payroll Protection and Healthcare Act. So it added money into the Paycheck Protection Program. Again, many of you probably heard that the funds were used very, very quickly for that. So it added an additional bucket of funds for that. And then it provided additional funding specifically to hospitals and clinics who are losing revenue and additional money for testing related to COVID-19. And then the most recent bill that was signed into law on June 5th was the Payroll Protection Program Flexibility Act, and it essentially gave business owners more flexibility and more time to use that loan money from the PPP program and still get it as forgiven. And so next slide, please. Rather than go through what was in each bill provision by provision, we thought it made more sense to just go over the larger buckets of funding that were included. And so this would be things that happened across all 5 of the different bills. And so that there was new funding for COVID-19 testing and treatment, direct payments to Americans, as I mentioned, revenue losses, community health centers, and hospitals. For example, there is something called the Provider Relief Fund, which in total is $175 billion, again, going to hospitals and community health centers. In the Families First bill, there was $100 million that was given to health centers. Specifically, California received 14 million of that. I don't know for sure how much of that has trickle down into Orange County. And then the CARES Act after that provided an additional $1.32 billion to health centers. And out of that, $193 million has come into California. So it's good to see that these funds are already coming into our state and likely into our county as well. And then there was funding for existing agencies and programs. And so these are programs that are already in existence and already get annual funding, but all of these agencies and programs got an additional boost. So for example, Healthy Start and the Temporary Assistance for Needy Family programs, the Ryan White HIV/AIDS program got a boost. Specifically, SAMHSA, which is the Substance Abuse and Mental Health Administration, given all of the new mental health issues people are facing, got increased funding, as well as the Health Resources and Services Administration. The Family Violence and Prevention Services Act got more money, and specifically programs that provide shelter to domestic violence survivors. So Congress was really looking at how can we bolster existing programs and where do we need to create new sources of funding. And then, as I already mentioned, the SBA loans, paid family sick leave, unemployment benefits. And then the other piece that Allison and I will spend some time on is, in addition to the funding part, there was some easing of federal regulations to make accessing care more easy and to make things smoother for both patients and providers when it came to the COVID-19 crisis. Next question. Next slide. So we thought we would make this a little bit interactive. And before I move forward, I'm going to ask a poll question of all of you, and that is true or false. Anyone can get tested for COVID-19 at no cost. Sydney has opened up the poll, so if you could take a few seconds to answer. Okay, Sydney, do we have the results? Okay, great. So 66% of you said true and 34% said false. Well, let's see what the answer is. Next slide, please. The answer is pretty much true. So the majority of you are correct. Anyone with Medicaid, Medicare, private insurance that complies with the ACA qualifies for free testing for COVID-19 with no copay or no cost sharing. That means literally the cost to the individual is zero. There are a few plans, they're known as short-term health plans that are not ACA compliant. Fortunately, those were actually banned in California, but they do exist in other states. And those specific plans do not have to cover the testing at no cost. Uninsured individuals in California do qualify for free testing under a new presumptive eligibility category under Medi-Cal, which I'll go into a little bit more detail later. And then undocumented immigrants federally do not qualify for free testing. However, I will talk about a bill that's pending called the HEROES Act, where some members of Congress would like to see this changed. The good news, again, in California always seems to have the better news, is that in California, undocumented or documented immigrants do qualify for free testing. So living here in California, pretty much anyone does have the ability to get testing for COVID-19 for free, which is great. Next slide, please. So I did already go over the testing when it comes to COVID-19 treatment. And again, these provisions can be found across all the different federal bills that I mentioned. Treatment is to be covered without cost sharing by Medicaid. Medicare said it will cover treatment, but there actually may be cost sharing involved currently if you are a Medicare patient. And then private coverage of COVID-19, whether you have an employer-sponsored plan, commercial plan, or even something on exchange like Covered California, there usually is cost sharing involved, and it varies from plan to plan. Something to note is that I will be talking about how states received an additional bump in federal funding for the Medicaid program, but part of agreeing to receive additional federal dollars was that states had to agree to this no-cost treatment for COVID-19 patients in their Medicaid program. And also there are some provisions being given to providers in the federal bills who choose to cover patients who can't afford COVID-19 treatment. They are able to get reimbursed for that as well. So that's just something to note. And then some of you may also be wondering about the vaccine. That's the top of everyone's mind, I think, when we talk about the future of what will happen with COVID-19. And so currently there is an entity called the Advisory Committee on Immunization Practices that actually issues the recommended vaccines. And it is very likely that they would recommend, once there is a safe and effective COVID-19 vaccine, that is something that should be administered. And both Medicaid, Medicare, and ACA plans all cover at no cost any ACIP recommended vaccines. So in all likelihood, most people would get access to the vaccine at no cost sharing. Next slide, please. And so I mentioned that there are a few Medicaid changes included throughout the bill. Two of the most important ones that I did want to mention. One was the 6.2% in federal Medicaid matching funds. So currently, for those of you who aren't aware of how Medicaid is financed, some of the money comes from the state, and then some of the money comes from the federal government. And the percentage that comes from the federal government varies state to state. You may have heard of it as the FMAP. In California, it's 50%. So that means that for every dollar that is spent on Medicaid, 50% of that comes from California and 50% of it the state pays for. What has happened with COVID-19 is that the federal government has said that it will bump up California's matching rate so that the federal government will now pay 56.2% of the costs associated with the Medicaid program, and the state can spend less of its own money on Medicaid and then use it for other purposes. And then it also eliminates certain Medicaid requirements, specifically face-to-face encounters. I'll talk a little bit more about telemedicine, but previously, in order to receive a certain type of care for a provider to get reimbursed, that encounter actually had to be in person, and due to COVID-19, it eliminated that requirement. Next slide, please. And then, of course, there were also changes to the Medicare program. It also, just like Medicaid, eliminated face-to-face encounters. It also increased certain Medicare payments for the treatment of patients with COVID-19 to providers. It permits a 90-day supply of any prescription drug during the COVID-19 emergency. So this is really helpful to seniors so they don't have to go every month to get a prescription refill. And then, as I mentioned already, the no cost sharing requirement for a vaccine when there is one that's developed. Next slide, please. And then there were two very specific provisions that aren't probably as well known, but very relevant to women's health that I did want to discuss. The first one is that in the federal legislation, there is language that permits the Small Business Administration to deny those PPP loans to abortion providers. What's interesting is that 38 Planned Parenthood affiliates across the country were in fact successful in obtaining these PPP funds, 80 million in total across all the affiliates. However, recently the administration has actually asked for that funding back. They've asked them to return loans, and their argument is, as an affiliate and as part of a federation, the Planned Parenthood Federation, they did not qualify as a small business because the federation in total has a lot more employees. Obviously, this isn't a very strong argument because the federation model is very common when we talk about, Komen or Boy Scouts of America and other organizations that have state or local chapters. And certainly they have received PPP funding and they are not being asked to return it. So that is something that is pending, and it'll be interesting to see how that plays out. There's also something called the Hyde Amendment, which always specifically states that no federal dollars can be used directly towards paying for abortions. It's pretty much included in any federal bill that relates to spending, and that HIDA language was also included in all of these federal bills, just to point out. And then also something that's interesting is a lot of people through their employers have something called health savings accounts, which means that you can set aside a certain amount of your pre-tax income into these accounts, and they can be used exclusively to pay for certain medical expenses, everything from contact lens solution to over-the-counter products. And it also applies to copays and deductibles and things like that. Two things happened with these federal bills. The first was even to purchase something like Tylenol or Advil using your HSA funding, you needed a note or prescription from your physician. So right now they have removed this requirement, so you can still use your pre-tax income dollars in your HSA accounts to buy those over-the-counter medicines. And then menstrual care products actually were never included as a medical expense that you could use your HSA funds for, and now they are. So that's a small but nice win for women when it comes to the ability to pay for certain things related to our healthcare. Next slide, please. And then I think, from a access to care and policy and regulatory standpoint, probably one of the most important changes that we saw in these bills were the telehealth changes. And so now private, Medicaid, Medicare, health plans, they all must allow patients to obtain healthcare through telehealth during this emergency. And there's really two main things that are important with these changes. The first one is that all of these payers are providing parity for both providers, which means that they are reimbursing providers the same amount for a telehealth visit or appointment as they would an in-person visit. And this is really important because before this wasn't the case. So a lot of times providers were disincentivized from using telehealth because they would actually receive less money from a telehealth appointment than they would do an in-person appointment. So this provides that parity, and it also provides parity for cost sharing for the individual. So if you had a $20 copay to go in and see your primary care physician, you still have a $20 copay to see that provider over telehealth. And then it also has temporarily relaxed enforcement of privacy laws when using telehealth. Typically, this is governed by a law known as HIPAA. So now any non-public facing remote communication product can be used for telehealth. This includes Skype, FaceTime, Zoom, Google, and the theory behind that was if a provider wasn't already using telehealth, it would have been very difficult overnight to develop a whole new system and adhere to all of the HIPAA standards. And so now all of these types of modalities are acceptable. Providers still may not use anything that's public facing like Facebook Live or TikTok or something like that. What's also important to note is providers still have to make that good faith attempt to act to protect someone's privacy. So just because they're using these quote unquote less secure modalities, they still have to make their best efforts to protect privacy. And then California also issued an executive order that has a few more provisions in it. For example, it suspends the patient consent requirement. And so before you had to consent in writing to do telehealth, this just speeds it up and takes away one more step. So you can just provide verbal consent for wanting telehealth. It also gives providers some leeway if there was a breach in privacy as to when to notify the patients. And then something else really exciting is that the California legislature actually passed a bill and it goes effect in January 2021 that makes the parity changes permanent. And so as you will hear Allison and I talk about throughout this presentation, some of these changes are limited to the COVID-19 healthcare emergency, and it's unknown whether or not they will be permanent or revert back after the emergency is over. In California, at least for commercial plans, the telehealth parity when it comes to paying providers will be permanent beginning next year. And so I think that we will start to see a lot more patients using telehealth and they don't feel like it's absolutely necessary to go in and see their provider. Next slide, please. And then I did want to quickly, as I wrap up the federal portion of the presentation, mention the HEROES Act. So this is known as the Health and Economic Recovery Omnibus Emergency Solutions Act. And it is the next piece of federal legislation that's being worked on. It did pass the House of Representatives on May 15th, so it's been almost a month now. And as it stands, it doesn't have a chance of passing in the Senate. It's seen as a Democratic bill, and it really is a wish list, so to speak, of all the things the Democrats would like to see in whatever coronavirus or COVID-19 bill is signed into law next. And so it is a starting off negotiation point. But I just wanted to highlight some of the policies that are out there that at least House Democrats would like to see. It's unknown right now, both chambers are working on a new bill, but it's unknown when that bill will be introduced and passed in both chambers and signed into law. But for example, in the HEROES Act, it does eliminate additional out-of-pocket costs for COVID-19 treatment and the vaccine. It provides even more money to hospitals and healthcare providers, even more Medicaid funding in addition to the 6.2% bump. Again, even more money to some of the agencies like HRSA and SAMHSA and to some of these programs that I mentioned, like the Violence Against Women Act and Family Violence Prevention Act. Specifically gives money to help people go in with nursing facilities who may be experiencing an outbreak. And it also expands the ability for tracing and testing efforts for COVID-19, where we still have a ways to go to bolstering those efforts as well. Next slide, please. And then it also focuses on preventing money specifically to outbreaks in the homeless population. And this is really important. Again, at the federal level, it allows unauthorized immigrants without healthcare coverage to qualify for no-cost testing, treatments, and vaccines. And then it also allows individuals for COBRA coverage to maintain their employer-sponsored coverage after a layoff, reduction hours, or furlough without having to pay premiums through January 2021. So again, it remains to be seen which of these provisions will end up signed into law, but it's good to know that these are at least in one bill that's passed the House. Next slide, please. And then finally, I'm not going to go through all of these bills for the sake of time, but I just wanted to raise awareness that there are a number of other bills that have been introduced related to COVID-19 and healthcare. And I just wanted to, when you have time, you can certainly go and look at the language. There's a brief summary, but just to kind of create that, again, awareness of other pending pieces of legislation that address specific policy issues related to COVID-19. Next slide, please. Okay, and so now I'm going to talk a little bit about the California May budget revise and touch at the very end on some legislative developments. Next slide, please. So many of you are probably aware that traditionally every year the governor proposes his budget in January, and then he comes out with something called the May revise every May. The biggest change this year, of course, was the COVID-19 crisis. And so whereas in January's proposal, there was a budget surplus, by the time the May revise needed to come out, the state is now facing a $54 billion deficit. So unfortunately, that means there were a lot of cuts that were made and a lot of new proposals on the table that were removed, or things that were supposed to go into effect this year that will no longer go into effect. And so some examples in cuts in funds for existing programs. There was money from the Proposition 56 tobacco tax that specifically gave supplemental payments to physicians, gave money for developmental screenings, provided money for family planning and women's health care. All of that money has been rescinded and the money is going to be applied to try to reduce the deficit. There's also cuts to money that was being provided for ACEs screening and provider training. There were some carve outs specific to federally qualified health centers. So that money was taken away. There's a decrease in WIC local assistance expenditure authority. And then there are also cuts made to a home visiting and Black infant health program. Next slide, please. And then there, as I mentioned, there are also delays in funding for new programs. So there were things that were tabled that we would have liked to have gone to see in effect this year. For example, the May revise continues to exclude low-income seniors who based on their immigration status. So before there was a proposal where regardless of immigration, low-income seniors would be eligible to apply for Medi-Cal. This would affect approximately 22,000 Californians. That is no longer on the table. It also reinstates something called the senior penalty in Medi-Cal. So remember that Medicare is for those who are 65 and older. And although it provides very good healthcare coverage, Medicare certainly still doesn't cover everything when it comes to healthcare costs, and there still are some gaps. And so there are seniors who, if they are low income, qualify both for Medicare because of their age and then also for Medicaid because of their income and poverty level. And these are known as dual eligibles. And before, you had to be at 123% of the federal poverty level in order to qualify for both Medicare and Medicaid. What January had proposed was bumping that up, so anyone at 138% of federal poverty level, which is about $17,000 a year, could be a dual eligible. Now they have dropped that back down to the original 123%. So again, we're looking at about 20,000 low-income Californians who could have also been dual, that are no longer be dually eligible. And then finally, it also delayed implementation of a bill that was passed last year, which would have extended Medi-Cal eligibility from 60 days to 1 year for postpartum women diagnosed with a mental disorder. And the good news is it does maintain level funding for some important programs related to women's health. And so it maintains funding for the Domestic Violence Assistance Program. There's funding for sexual health education, STI treatment, and all of those, there have not been any cuts made. And so it really is a hard balance trying to figure out where to cut and how to cut when the deficit is so huge. So we just wanted to bring awareness to all the things that have been proposed thus far. Next slide, please. And then finally, there are California bills that are still in play. What is different about the California legislature versus the federal legislature is that in the federal Congress, you can introduce bills year-round. There's no deadline. In California, there actually is a deadline to introduce new bills, and that was in February, actually, before all of the COVID-19 crises hit. And so there are no quote unquote new bills that have been introduced specific to the COVID-19 emergency. However, some are certainly more relevant now than they were before. And so the legislature is now back in session for a limited number of days. And what we've been told from some of our partner organizations who are more closely tied to Sacramento is that the legislature will be focusing on very limited number of bills that either are directly related to COVID-19, housing, homelessness, or wildfires. Each senator or assembly person has basically been asked to give their top 1 or 2 bills that they would like to see advance. And most of the bills have to have no cost associated with them, or of course, an added bonus is if it lowers the deficit in some way. So again, a lot of the focus will be around the budget. This by no means, what you see in front of you, is an exhaustive list of bills that are still in play. These are just a few of the bills that we've been made aware of that kind of qualify under no cost. They're a top 2 priority of the member that introduced them, or have a significant role to play when it comes to COVID-19. And with that, I will now turn it back over to Allison to go through some of the state regulatory developments. Thank you.
Yep. Thank you, Mona. So next slide, please. Actually, 2 slides ahead. I'm going to talk briefly about what's happening at the state level in terms of changes to rules and regulation to facilitate access to care during the COVID-19 pandemic. I'll also be reviewing some interesting legal developments that are either directly responsive to the pandemic or playing out during the pandemic. So to begin, as Mona explained, the federal legislation and the way that California has operationalized some of the legislative changes have allowed for the creation of a new type of presumptive eligibility for Medicaid, which in California is referred to as Medi-Cal. So if anybody in California is uninsured, or if they have private insurance that doesn't cover testing or treatment for COVID-19, then they do now qualify under this new category of presumptive eligibility under Medi-Cal. This also allows, in addition to testing and treatment for COVID-19, for the 90-day supply of medication, similar to what we heard about under Medicare. In addition, disinfectant products and gloves are now treated as temporary covered pharmacy benefits, provided that a prescription is written by the provider. And also of note is that Covered California has extended their open enrollment period through the end of this month, June 30th of 2020. It's nice to know that all the presumptive eligibility channels, such as Medi-Cal presumptive eligibility, are now accepting applications by telephone as opposed to strictly in writing in person. Next slide. Now I'm going to talk for a few minutes about some of the regulatory changes in specific topic areas, starting with sexual health. In California, we have a special publicly funded program called Family PACT, which is Family Planning, Access, Care, and Treatment, also known as FPACT. It's a carve out of our Medi-Cal program. And prior to the COVID emergency, Family PACT did authorize the use of telehealth for certain purposes. That has been expanded in response to COVID-19. Telehealth can now be used to enroll new applicants, to recertify existing participants, and for special types of consults and visits, which can be conducted over the phone or by video conference, using some of the less secure modalities that Mona mentioned before. So I just want to take a moment and step back and say, telehealth is not new to COVID-19. It's been much more broadly implemented and authorized. And prior to COVID-19, in order to use telehealth, providers had to use HIPAA compliant modalities, and there were special types of technologies developed. So various electronic health record or EHR systems would often build out a telehealth component, or certain other types of products like Zoom came out for Zoom for healthcare. So for specially designed technology platforms for virtual visits, whether on the phone or whether on video conference, that were authorized as compliant with HIPAA to ensure security and privacy protections. And the biggest change is that now we've relaxed those standards, and modalities that are not quite so secure are permitted to be used during the COVID-19 emergency. Another benefit under the Family PACT rules changes is that utilization limits on medication have been waived, and self-administered birth control shots, Depo-Provera, which gets usually inserted in the arm. Those can be self-administered at home and covered by family packs so long as they're under the guidance of a provider. I do want to acknowledge one other critical change, which is prior to COVID, in order to utilize telehealth, there had to be a pre-existing relationship between the patient and the provider. So they had to have had at least one in-person visit before they could use telehealth that would be covered by family pact. Since COVID, however, that pre-existing patient-provider relationship is not required, which means that the first encounter that a patient has with their provider under family pact can be on telehealth platform and still be covered. You can also consent your patients on the phone. It no longer has to be done in writing and in person, at least for the duration of the pandemic. Next slide. The next area I'd like to talk about is the breast and cervical cancer arena. And similar to the changes with family pact, the Every Woman Counts and breast and cervical cancer treatment programs also are now allowing patients to enroll and recertify using telehealth instead of having to do so in person and in writing. It can be done on the phone. And primary care providers who are covered by Every Woman Counts or BCCTP are now authorized to use telehealth for delivering covered services where medically appropriate during the pandemic. Thank you. Next slide. There's also been some changes in the domestic violence space. The governor recently, as of just, I believe, May 29th, signed an executive order that achieves the following. The first is that the largest public funding source for domestic violence programs is called the Domestic Violence Assistance Program, or DVAP. And historically, prior to COVID-19, any agency that wanted to apply for DVAP funding had to demonstrate that they could provide a 10% match for any public funds that would be received. And the emergency order now waives that 10% match for domestic violence applicants for DVAP funding. There's also been an allocation of $3 million from the California Office of Emergency Services to domestic violence agencies to support their response to COVID-19. So as you can imagine, in any type of shelter where, which is an essential business, steps have to be taken to increase sanitation, to try and facilitate social distancing, which may be difficult in a confined space. And equipment and training may have to be purchased to facilitate telephonic or video conference-based service delivery. And so these funds can be spent on those types of expenses or even purchasing additional cleaning supplies and so on. The state is also partnering with several agencies to provide free transportation for domestic violence survivors through Uber, as well as free accommodations through Airbnb. I also want to mention that the Judicial Council, which is the state regulatory body that oversees the courts, has adopted some emergency orders for the COVID-19 emergency. They have extended emergency protective orders, which typically would be awarded to a domestic violence survivor for about 5 to 7 days. Those can now be extended to 30 days. The purpose, of course, is to minimize the number of times that an applicant has to go to court. And in a similar vein, these emergency protective orders can now be applied for using remotely using a platform like Zoom. This means that an applicant no longer has to come to court to apply in person. Next slide. Legal developments. So we've seen some interesting litigation surface during the COVID-19 pandemic, and there's also some very important Supreme Court cases that are being decided during the same time frame. So I'm going to start with a lawsuit, next slide, that was recently filed by the American College of Obstetricians and Gynecologists, ACOG, as well as several other medical associations, in tandem with several reproductive justice organizations like Sister Song. These organizations are challenging the FDA's rule that requires patients to go to a hospital, clinic, or private medical office to pick up a medication abortion pill. So in the United States, about 39% of all abortions are actually done using medication. And the medication at issue in this lawsuit is mifepristone. It's actually a combination of two pills that are taken. And prior to COVID, the FDA protocol actually allowed patients and providers to do the initial consult and any counseling related to medication abortion on the phone. And then the patient has to go and pick up the prescription in person, but then they can go home and take the pill. Literally, the act of swallowing the pill can take place outside of the supervision or presence, at least, of the healthcare provider who prescribed the pills. So interestingly, during the COVID-19 emergency, the FDA suspended this in-person pickup requirement for 18 of the 19 drugs that the FDA oversees. Of course, the only one that the FDA is still requiring patients to go and pick up in person is mifepristone. And so this lawsuit is intended to do away with that discriminatory treatment because it does interfere with patients' ability to access this legally provided medication. And if it's not being picked up in person, it can be delivered via mail through mail order pharmacy, or at least dispensed by telehealth. So that's the purpose of this litigation. And there are links to the bottom if you'd like to read the complaint or if you'd like to learn more about the case. Next slide. A number of states have taken the interesting, pretty clever step of issuing their public health emergency declarations to include abortions as non-essential or elective health procedures. In other words, they don't feel that time is of the essence when it comes to abortion. There's been a slew of litigation challenging these declarations. And as of today, there is one such state declaration that is still in effect, which effectively bans abortion during the COVID-19 pandemic. And that ban is still in effect in Arkansas. But the bans in all of the other states have been either blocked altogether by court order or at least temporarily suspended because of a settlement or some type of executive or government action. Next slide. So you can see that on the map here that most of the states in question that have taken this extraordinary step are in the South. The only state that still has an active ban in effect is Arkansas. Next slide. There are two interesting cases that are pending right now before the Supreme Court. The first is a case about abortion access. This case is called June Medical Services versus Russo. It actually used to be called June Medical Services versus G, but there's been a change in personnel at the Public Health Department from G to Russo. That's why it's a new name, in case you've been following the story. The Supreme Court held oral argument on this case on March 4th, and we will receive a decision from the Supreme Court by the end of this month, because that's actually when the term ends, June 30th. So all Supreme Court decisions have to be released by June 30th. It's now June 10th, so it's literally any day now. This case challenges a law in Louisiana that requires abortion providers to have admitting privileges at a hospital within 30 miles of their clinic. It may sound on the surface like an interesting idea, but actually in 2016, the Supreme Court struck down a law in Texas that was substantively identical to the Louisiana law that's in question right now in June Medical Services. And the court found that there's actually no reason to require hospital admitting privileges if the stated purpose is to protect women's health. These laws do nothing based on the medical evidence that was reviewed by the Supreme Court. These laws do nothing to actually protect or advance women's health. In fact, they do the opposite. They restrict access to abortion. The reality is, in conservative states, many hospitals refuse to provide admitting privileges. But this is all kind of a red herring because most, well, first of all, abortion is considered one of the safest medical procedures, and the complication rate is very rare, and even rarer for a complication that requires hospitalization. And in those cases, a patient can simply show up in the emergency room. They don't have to have a physician with admitting privileges. They will be seen, they will be treated at any emergency room at which they appear. At least they should be under the law. And so under the current jurisprudence or the legal philosophy of the Supreme Court, the threshold question is, does an abortion restriction passed by a state create an undue burden on a woman's constitutional right to access abortion? And in 2016, in the Supreme Court case, Whole Women's Health versus Hellerstedt, the court found that the Texas law, which is substantively identical to the Louisiana law, in fact, created an undue burden and therefore was struck down as unconstitutional. There is another question that's at issue in this case, which is whether providers actually have standing, legal standing, to bring the lawsuit in the first place on behalf of their patients. And the court can decide either or both of these legal questions to dispose of the case, but really the larger question is whether this particular restriction constitutes an undue burden. Next slide. The second Supreme Court case is called Little Sisters of the Poor versus Pennsylvania. And there's actually a companion case, Trump versus Pennsylvania. These two cases have been consolidated. There was oral argument on both of these cases on May 6th, and a decision again will be released by June 30th. And this case is about contraceptive coverage. So the Trump administration recently enacted a new rule that exempts a wide range of employers from having to provide coverage in their health insurance plans for contraception. And the legal challenge is whether this exemption is constitutional or is it unconstitutionally overbroad. There's also some legal questions and challenges raised to the procedures by which the Trump administration passed this rule and whether the Trump administration violated the Administrative Procedures Act in the way that it passed the rule. That's more of a procedural question, but the substantive question really harkens back to the Affordable Care Act, which require, and actually Mona, my colleague, helped to draft this section of the Affordable Care Act. And the section in question requires most employer-sponsored health plans to include coverage for contraception in their health insurance plan for their employees. Now, even at the time this was introduced back in the Obama administration, there was an exemption for religious institutions. So churches, temples, synagogues, mosques, religious institutions whose primary purpose is to inculcate religious faith. They were exempt from having to provide contraceptive coverage if that provision conflicted with their religious views. During the Obama administration, as this was implemented, there was a slew of litigation by different types of employers claiming that they should be exempt as well. And over the course of many years and some forced mediation from the Supreme Court, the Obama administration and many of the plaintiffs worked out several solutions, including an accommodation in which a religiously affiliated employer, so let's say a hospital that is religiously affiliated with a Catholic church, or maybe a school that is run by a religious organization. If these were religiously affiliated employers, that they could seek an accommodation and submit some paperwork to the federal government stating that they had a conflict with their religious views in providing this coverage. And then the federal government would take over from there and facilitate the provision of contraceptive coverage to employees of the religiously affiliated employer at no cost to that employer and actually no further involvement. So there was no administrative burden and no cost once the federal government took over. That wasn't enough, and we are now seeing another round of litigation. And in response, with the change in administration, the executive branch has now issued a whole new rule around contraceptive coverage, and that's where we are today. So the Trump administration's final rule exempts not only religious institutions and religiously affiliated institutions, but also any nonprofit employer, as well as any for-profit corporation that is not publicly traded from having to provide contraceptive coverage. That's a pretty wide range of employers, and that's the basis of the challenge. Is this exemption overbroad? So we are waiting to hear what the decision is going to be from the Supreme Court. I mention these two cases because they're pending at this time, and the court does not exist in a vacuum, and there's a lot of speculation as to whether the realities of the COVID-19 pandemic and how that has impacted access to reproductive health services, whether that will inform the court's decision. Nobody really knows, but I think it is important enough to acknowledge that these decisions have not been rendered yet, and yet the oral argument did reflect, and some of the questions did reflect the reality of the COVID-19 pandemic. So we will be keeping you posted on our website and our social media posts once these decisions are released. Next slide, please. So all of this is a very exciting review of the many important funding, legislative, and regulatory changes that have already happened to respond to the COVID-19 crisis. But it really begs a larger question, which is, what have we learned and what should we leverage for the long-term rebuilding that will follow this pandemic? So what are some of the issues and learnings that should inform our future policy and advocacy efforts moving forward? Because we have seen how effectively this pandemic has highlighted the deeply entrenched inequities in our health system in this country, and how communities of color, low-income communities, the immigrant population, LGBTQ individuals, and women have experienced negative health outcomes due to these long-time institutional barriers and disparities in care. So how can we address those moving forward as we rebuild post-COVID-19? So the top of line question is, which of these responses, whether funding, legislation, or regulatory, that are currently temporary, should we push to make permanent? Some of the things that are on the table are the availability or authorization for remote consent, the ability to enroll and recertify applicants by telehealth or over the phone, this notion of parity in reimbursement for telehealth, meaning that providers should be paid the same regardless of whether they are delivering care in person or on telehealth. Even the question of relaxing the privacy protections, I think, is going to be up for debate. We also are looking to how do we protect the safety net moving forward, especially in light of our massive state deficit. And we're really interested in hearing what you're thinking about. What are your organizations working on, or what's your dream wish list in terms of policy items moving forward? And you are welcome to chat your ideas to us. We also have included a question in the evaluation survey where you can submit your ideas. Next slide, please. Finally, we've just compiled on this one slide the resources if you'd like to learn more. Obviously, most of our slides have sources at the bottom, but these are kind of higher level across the board if you'd like to learn about how, what are the new telehealth coverage policies, how are Medicare and Medi-Cal responding to COVID-19, and some of the specific state programs like Every Woman Counts and Family Pact, as well as where you can find more information, including commentary, as well as all of the pleadings for the Supreme Court cases that I mentioned earlier. Next slide. And with that, we are going to, this is our contact information if you'd like to contact us. And next slide, we're going to now move into the Q&A. Aurora will moderate the Q&A for us.
Great. Thank you both, Allison and Mona, for these informative presentations. I'm sure everyone really appreciated the information you brought today. It looks like we do have a few minutes to get to a couple of questions. So before we get started with the questions, I just encourage all the participants to type in your questions in the Q&A function. As Allison mentioned earlier, if we don't get to those questions during the session, they will be answered and answers will be posted on the summit's website. So to get us started, I know earlier on in the presentation, Mona mentioned testing for undocumented immigrants. So with that said, I'm wondering if you all have any thoughts around whether public charge will be an issue that will come up around folks who are trying to access COVID-19 testing and treatment. So open it up for either of you to respond to that, and I'm happy to chime in as well.
Thank you. So for those of you who aren't aware, public charge is a regulation that went into effect that takes into consideration when someone is seeking, oops, we good? Okay, all right. When someone is seeking legal status in the United States, whether or not they were using certain public programs. And it's caused a lot of controversy and angst because even though it's been a long-standing rule, this current administration has significantly increased what it means to be considered a public charge. And the good news is, according to the state of California, is if you are an immigrant, undocumented or documented, and if you do become part of that new presumptive eligibility group for COVID-19 testing or treatment under MEDICAID, that does not count towards the public charge rule. Before we post these slides publicly, we will add a link to the additional resources pages that directs you to more information. And Aurora, certainly working with the community health centers, you probably have more direct knowledge of this, so feel free to add anything else you want to share as it relates to public charge.
Thank you, Mona, for that. And again, at the Coalition OC, we have done some work around public charge just to make sure that the community has the information they need to know what benefits they should be accessing. And so just two things that I really want to emphasize is, again, we don't want folks to feel limited from seeking treatment and testing for COVID-19 because of their immigration status. So we encourage you all to really encourage families to get the support that they need and that it won't be a risk to them. And the second point that I wanted to make to that was we are involved with the Protecting Immigrant Families Coalition that has a lot of really helpful resources to help folks understand what public charge is. They also have on there some information about COVID-19. So if folks are interested in learning more about that, please visit protectingimmigrantfamilies.org, and I'll make sure to type this into the chat as well to get more information. So thank you both. For another question is, Mona, you talked about telehealth. Well, actually, both of you talked about telehealth. So we want to know, why is telehealth so important? Not just during the pandemic, but pre and post the pandemic. Why should we all be paying attention to what's happening around telehealth, and why is this so helpful to making sure that our communities are able to access the care they need?
That's a great question. Thank you, Aurora. The early feedback from the expanded use of telehealth has been incredibly positive. Some of the social determinants that can really influence health outcomes and even access to health are barriers like whether somebody has access to childcare, whether somebody has access to transportation, whether somebody can make it to the doctor's office during regular working hours, or if they can only, maybe they're working several jobs and they can only get to the doctor's office or a clinic during off business hours or on the weekends. So especially during a pandemic when we're all supposed to be sheltering in place or working an essential job, it's even harder and riskier to be out in public or going into a medical site can be very frightening. So making so many different types of services and consultations available by telehealth vastly expands access to healthcare while also mitigating the risk associated with receiving healthcare in person. Hospitals and clinics are trying their best to minimize the risk of spread. They don't want to become transmission sites, and they've taken great steps to segregate COVID from non-COVID patients. So anything we can do to minimize the number of bodies walking into a clinic or a hospital or a private medical office setting is going to go a long way to limiting the spread of COVID-19. So it's really primarily an equity issue. We are vastly facilitating broader access to care by utilizing telehealth, while also, in terms of the pandemic itself, mitigating the risk.
Thank you, Allison. I really appreciate that. And I know from the Coalition OC's perspective, working with community health centers, that's also really important, as community health centers have been financially impacted by COVID-19 pandemic, and the ability to still be able to provide services via telehealth has really been helpful. And I'm not sure if Mona, you wanted to chime in as well.
Actually, Allison, I think, covered the main kind of broader policy goals that we're trying to achieve with telehealth, but thank you.
I would like to add one comment, since I did point out that this is an equity issue. On the flip side, a number of communities do not have access to telehealth. They don't have the technology. They're not familiar with how to use it. There could be language barriers. So I think any forward-looking policy work to be done around expansion of telehealth also has to address these underlying issues as well. So I think the long-term goal and benefits we're already starting to realize right now in this COVID-19 emergency. But as we look forward to how to make this a permanent option for providers and their patients, we have to be sure that we address the underlying technological access issues. Thank you.
Thank you, Allison. Yeah, I definitely agree with that. As folks who are out there doing outreach and education work, I think that's something we need to think about too, right? It is a cultural shift to shift from getting in-person care to telehealth. So we also should be thinking about how we can be a part of bringing that education and awareness into our community. So thank you so much for highlighting that. So it looks like I have time for one more question. So for Allison, I know you talked about various regulatory changes. So I just wanted to ask, how long will these regulatory changes last for?
That's a million-dollar question. A number of the changes in California have been defined as temporary during the public health emergency. And that's true also at the federal level. Unfortunately, we don't know when the public health emergency will be officially declared over. So long as the public health emergency orders are in place, we can expect that these regulatory changes and the easing of various rules and regulations will continue for the duration of the pandemic. The public health emergency is the kind of classification of authority that allows the federal government and states to issue these changes in an expedited fashion. And COVID-19 is considered a public health emergency. What's going to happen after the public health emergency is eventually declared over? That's anyone's guess, but that's why it is important for us to be doing the planning now. If there are things that we want to see made permanent, we need to start tracking and building a case. So if your organizations are in fact utilizing telehealth, please monitor how well it's being utilized. What's your satisfaction among patients and clients? I don't know if you're asking these questions, but do what you can to collect information and feedback, not only on whether telehealth is effective as a vehicle for delivering healthcare and leads to positive health outcomes, but also what's the satisfaction level among your patients and clients. And for those who may have experienced challenges in the first place with the technology, or maybe they don't have strong Wi-Fi, or they don't have a private place in which to use telehealth, whatever the underlying challenges are, how have you been able to solve those problems? It will be immensely helpful for you if you are tracking those types of issues with some qualitative feedback from your patients, your clients, and also your staff. How are your clinicians, your counselors, your therapists, how are they experiencing telehealth? We've heard that doing the same thing online is a lot more exhausting than doing it in person. And if you have back-to-back virtual meetings on Zoom or whatever your platform is, that can be pretty taxing. And so any learnings that you can share along the way to how to make this easier, how to make this engaging with patients and intimate and comfortable, so that there is that the use of telehealth doesn't in any way disrupt that important trust that is built and cultivated through the course of a patient-provider relationship. How do we ensure that the use of telehealth doesn't in any way derail that trust? So these are all important things to track and consider, so that when the public health emergency ends, we have really good information and can be very thoughtful in what the ask is long-term.
Thank you, Allison. I really appreciate your response to that. I know there's a lot of lessons that we have already learned and that we want to continue to learn to make sure that we more effectively are able to respond to health crises and other crises that we may be facing. So I appreciate that. So with that, I would like to thank our esteemed panel for their time and sharing their expertise with us today. We appreciate the amazing work you're all doing around women's health policy issues and identifying opportunities here in Orange County. We really appreciate your work. So with that, thank you again for having me here. And I would like to invite Allison to close out today's summit session.
Thank you. Next slide. So that wraps it up. Thank you, Aurora. Thank you, Mona, and the whole team. This wraps up our session for today. I just want to remind you to please complete your evaluation survey. It should automatically pop up at the end of the session as you exit the Zoom. But if you don't see that link, or if you're not redirected, you can find it on the Summit website. If you are interested in continuing education units, please remember to complete not only the evaluation survey, but also the CEU request form. And please join us for the fourth and final session next Wednesday, June 17th, which will explore the very important topic of how is COVID-19 affecting mental health and what new solutions and services are available. Thank you so much for joining.